Welcome to this program entitled Putting a Personalized Colorectal Cancer Treatment Algorithm into Practice. We will navigate through practicalities in the era of molecular-defined care. I'm Eric van Cutsem, Professor of Medicine at the University of Leuven in Belgium, and I'm happy and honored to be joined by Dr. Scott Kopetz from the University of Texas and the Anderson Cancer Center in Houston.
Thank you, Dr. Van Cutsem. It's a delight and a privilege to be with you today.
I'd like to thank you to Peerview for providing this session, and also Lilly, Merck, and Pfizer, and Taiyo Oncology for providing the educational grant for this webcast. Look out also for poll questions during the session, and ask the questions to the faculty by entering them in the space provided. Here you can see my disclosures. And on this slide, you can see the disclosures of Dr. Kopetz. And also relevant to mention is that the team of Peerview Institute for Medical Indication does not have any financial disclosures. And also important to mention is that we may discuss drugs investigation for investigation use outside of the indications of FDA, but we will be transparent on that and mention that. Also relevant in the introduction is to repeat that you can visit us at this website. You can follow us also through Twitter. You can download the slides and practice aids and apply for CME credits as is explained on this slide. The program consists of 2 modules, and afterwards we will have a discussion. And as I mentioned already, please do submit questions on this topic. We will be delighted to answer them. In the first module, I will discuss a topic with optimizing treatment selection and sequencing in advanced metastatic colorectal cancer with novel systemic approaches. And Dr. Kopetz will discuss in Module 2 personalized colorectal cancer therapy with novel biomarker-driven treatments. So let's continue with developing this topic on individualizing, personalizing the treatment option for patients with metastatic colorectal cancer, and taking into account some of the activity of the new agents and some of the market data. And Scott will develop later on details on biomarkers. It is unfortunately a reality that still some oncologists today don't do a complete molecular analysis of the tumor, don't look at MSI, MSS status, don't look always at RAS and BRAF status before trying to start a treatment strategy. And that's true in some countries. There are some real world data that show us that is still a reality today. But of course, one of our goals of Dr. Kopetz and myself is to demonstrate you how pivotal and how important it is to use all the knowledge that we do have on molecular markers in order to propose to the patient the best treatment option that is possible. And that brings us in how we can develop in a rational way some of the different treatment options for patients. Start with developing the treatment options in first line, and then later on, I will develop the treatment options in second and later lines. What is true is that molecular markers are relevant, but individualization and personalization of the treatment options, it's not only the markers which are relevant, and this slide is derived from the ESMO consensus, It's also the tumor localization, tumor burden, and on top of that, some patients and treatment characteristics. Treatment characteristics such as the toxicity profile, socioeconomic factors, the quality of life that goes alongside with the treatment options, and some patient characteristics such as the age of the patients, the performance status, the organ function, the comorbidities. And the art of medicine is to integrate all these treatment, these characteristics that determine what we do, um, and then integrate that in order to come up with an as much personalized and individualized treatment option for our patients. And if we translate and look into that, we can look into the ESMO guidelines, we can look into the NCCN recommendation in this situation, then we see different options. We can start, most often, most patients start with the chemo doublet, FOLFOX, FOLFIRI, maybe Capox. Occasionally, we start with a triplet, FOLFOXIRI. We can add to this doublet or triplet a biological, and this may be bevacizumab, or this may be an anti-TGR antibody being cetuximab or panitumab for RAS and BRAF wild-type patients. Or even today, after the recent approvals of checkpoint inhibitors and some recent data of combination of checkpoint inhibitors, as well in the first line as in later lines of treatment for MSI-high patients, we can add clearly, and that's what you can see highlighted here in red on the slide, um, the option of pembrolizumab, or eventually of a combination of nivolumab plus ipilimumab for the MSI-high patients. And I will discuss later on in detail some data with checkpoint inhibitors. And then there are patients who are not good candidates for more intensive treatment. There we can go for either fluoropyrimidine alone with bevacizumab, for instance, and this can be intravenous or oral fluoropyrimidine for these patients. Or in the future, who knows? We don't have yet enough data for BRAF V600E mutant patients for a targeted treatment, or for HER2 positive patients for an anti-HER2 targeted treatment. These are not yet recommended options for the first line treatment in metastatic colorectal cancer. But looking at the previous slide and at the different options, in fact, we have a whole spectrum of intensity of the treatment that we can administer and propose to the patients. We can go for a more intensive treatment, like, for instance, the data here from the phase 2 study, the VOLFI study, which was probably one of the most intensive regimens with a triplet FOLFOXIRI plus an anti-TGR antibody, and especially RAS and BRAF wild-type patients who are localized on the left side. There are really data from different trials that with this more intensive treatment, that we can see in more than 80% of patients in the first line treatment an objective response. Of course, we do not treat all patients with such an intensive treatment. There is a tendency for at least some patients to treat them with the triplet FOLFOXIRI with bevacizumab. Um, the Italians have shown that the triplet FOLFOXIRI plus bevacizumab may be a bit better than a doublet plus bevacizumab. However, that's not accepted for granted by everybody. And in my practice in Leuven, I treat most patients with a doublet. But there are some patients who also are not candidates for a doublet. And then we give them either intravenous, either oral fluoropyrimidine, so 5-FU or capecitabine, often in combination with bevacizumab. And there also we have some data, for instance, from the TASCO-1 study, showing that TAS-102, trifluridine depressor, as we call it in Europe, so TAS-102 plus bevacizumab in the randomized phase 2 study was at least as good compared to capecitabine bevacizumab, at least for patients who are not good candidates for a doublet or a triplet. So the whole spectrum, and the art is indeed to individualize that. And these are the data from this TASCO-1 study. It's a randomized phase 2. It's not a phase 3 study. I presented at the last ASCO GI meeting the updated overall survival results. And If you look at the overall survival for this group of patients, often elderly patients, not candidates for doublet or triplet, or patients in worse condition, you can see that the overall survival for test 102 plus bevacizumab was 22 months. For capecitabine, bevacizumab was close to 18 months. This is a randomized phase 2 study. A randomized phase 3 study is at the moment ongoing for our in this situation to see whether that's a real option for these patients and whether the combination of TAS-102 bevacizumab is better at capecitabine bevacizumab. But the monotherapy fluorouracil plus bevacizumab is an option for patients. Tumor markers, molecular markers are not the only factor that drive our decisions. Also, the sidedness of the primary tumor drives our decision. And if you look, for instance, there are these are data from an ESMO analysis, but there are other analyses that have been done where we did a combined pooled analysis from data from different trials. We have shown that the sidedness was prognostically important in the first line. So patients with a left-sided tumor had a better prognosis compared to patients with a right-sided tumor. And on top of that, sidedness is predictive. Patients with a left-sided RAS type tumor, they have more benefit from a chemotherapy combination in combination with an anti-EGFR antibody, while patients on the right side do slightly better with chemo plus bevacizumab. So this sidedness also comes into our treatment algorithms, into the individualization. And today in Europe, for sure, we look at this tightness as being extremely relevant for taking decisions, especially in RAS wild type patients, especially in the first line treatment. As promised, I would come back to checkpoint inhibitors. These are the data of the well-known, or the design of the well-known Keynote 177 study, in which patients with an MSI-high tumor or a deficient mismatch repair tumor were randomized between a standard chemo doublet with a biological, it was with bevacizumab or cetuximab, and the other group, the experimental arm, received pembrolizumab. The primary endpoints were progression-free survival and overall survival. And looking at the data as they were, we published the data in New England Journal of Medicine and updated them at the last ASCO and ESMO GI meeting. Pembrolizumab, patients treated with pembrolizumab had a clearly longer progression-free survival compared to patients treated with chemo. And also looking at the progression-free survival too, there was an improvement for pembrolizumab versus chemotherapy. The overall survival, although numerically better for pembrolizumab compared to chemotherapy, was not statistically significant better. The p-value was 0.035, but the preset p-value was lower. So statistically, there was no difference, but numerically and clinically relevant, there was a difference. And the fact that we missed the statistical difference can be for sure explained by the fact that 60% of patients that were treated initially with chemotherapy received crossover its second line with the checkpoint inhibitor. And it's obviously, it's logical also that this will decrease the difference in survival. There was also a higher response rate and with pembrolizumab compared to chemotherapy. And on top of that, the response duration was clearly long. One of the questions is, do we give in the first line treatment a PD antibody alone? I've shown you the pembrolizumab data. We have data from non-randomized studies, Checkmate 142, in which there were different cohorts, but here I report on the cohort in the first line. It was a small cohort, non-randomized, first line treatment, MSI, with nivolumab plus ipilimumab. Response rates were high, were 69%, but when we look at the longer follow-up data, response duration was quite low in these patients, as well as the PFS and the OS in these patients. We do not have yet randomized data of a PD antibody, pembro or nivo, versus the combination of a PD antibody plus an CTL4 antibody. There is an ongoing study of nivo versus nivo plus ipilimumab in the first-line treatment of MSI-high patients. And as long as we do not have the data, at least in my practice, in most of the patients, I will treat them with a PD antibody alone. Pembrolizumab is approved in this setting, and will keep nivo plus EP eventually in later lines. But of course, that may change in the future if we would see that nivo EP would be better compared to pembro. And looking at cross-trial comparisons for a response rate, we see that nivo EP leads to high response rate, which are in cross-trial comparisons higher compared to pembrolizumab. Another option in the future that we could look at, that we've been looking at already in the first initial non-randomized study, is BRAF targeted therapy in the first line. And indeed, I reported at the recent ESMO GI meeting the data of the ANCHOR study. This is a non-randomized study in 95 patients with a BRF600E mutation at first-line treatment with a combination of cetuximab plus BRAF inhibitor and corafenib plus the MEK inhibitor binimetinib. And indeed, in this study, in the anchor study, and we reported that the objective response rate was 48%, which is quite good. But we do not know whether that's better compared to the standard options, and I'll come back to that, that we do today for patients in the first line treatment of metastatic colorectal cancer with the BRF600E mutation. Progression-free survival, uh, overall survival was quite good, was better than what we would have predicted in this situation for these patients. Quality of life also that we measured, although it's not randomized data, so it's not always easy to conclude on that, but quality of life also was remained quite okay in this group of patients. It's going to be relevant to see and to look at the data of the breakwater study. That's the study in the first line treatment that is ongoing. It starts with the safety lead-in in BRF600E mutant patients with the chemo backbone, FOLFIRI, or a group of patients, FOLFOX, plus cetuximab, plus the BRAF inhibitor and corafenib. If once we have found a feasible and tolerable dose, there will be a randomization in 3 groups. For BRF600E mutations, first line, investigator's choice, chemo doublet or triplet with bevacizumab. The experimental arms are encorafenib cetuximab, arm A, and the other experimental arm is encorafenib plus cetuximab plus a chemo doublet. To see what is best option, can we go for a BRAF targeted therapy, or do we need to combine BRAF targeted therapy and corafenib cetuximab with chemo? And is that better than chemo alone in this situation? So that's an ongoing study. It will take some time before we have results. Going back to checkpoint inhibitors, there are some other studies ongoing. This is, for instance, the phase 3 COMET study run by the SMOG also of atezolizumab in the first-line treatment of MSI-high colorectal cancer patients. And there were 3 arms. There was a chemo arm, chemo plus bevacizumab, but that arm has been permanently closed after we saw the data of Keynote 177 with pembrolizumab in the first line. Arm 2 are patients treated with a checkpoint inhibitor alone, a PD antibody, atezolizumab, and arm 3 are patients that were treated with chemo, FOLFOX, plus bevacizumab, plus atezolizumab in this setting. So a lot of activity ongoing, a lot of new data will help us to personalize the treatment options for patients with metastatic colorectal cancer. I'm dealing with second and later lines of treatment, looking at the NCCN guidelines for patients treated often with oxaliplatin-based chemotherapy without irinotecan. In second line, we can switch the chemotherapy backbone towards irinotecan. Or if patients have an MSI high tumor, we can go for Nivo EP, for instance, or pembrolizumab if they were not yet exposed to an anti-PD antibody, or even anti-HER2 target therapy can be an option. And then later on, we may go, depending on what we did in second line, to an to regorafenib, trifluridine diprasil, or as you call it in the West, as 102 plus or minus bevacizumab, or a targeted agent in this situation. So that's what is put on the NCCN guidelines. And I developed some of the aspects here in order to learn better and more how we will guide our treatment decisions. And that's in fact a little bit another scheme, but based on an update of the ESMO guidelines, what we'll do in second line. If you look in second line, the goal of the treatment that is more relevant in first line being disease stabilization or cytoreduction, this comes together in second line. In second line, it's extremely important to look at molecular characterization, RAS wild type, RAS mutant, MSI-high, BRAF mutants, HER2 amplified, and track alterations or other, and then also to look at the frailty. And with that, we can come up with different treatment options for our patients. Looking at the classic treatments with chemotherapy. If patients, and that's the case in my practice, and that's often also the case in the US, are treated in first line with a FOLFOX backbone, in second line, we often switch to FOL3, and we can then add an angiogenesis inhibitor. We have data with bevacizumab, aflibercept, ramucirumab. There are no head-to-head comparisons of these different angiogenesis inhibitors. There are cross-trial comparisons. All trials met the endpoint and improved the overall survival. The aflibercept trial showed on top of that there was slightly higher response rate. But on the other hand, aflibercept is a bit more toxic compared to bevacizumab. So in clinical practice, we often use bevacizumab in these patients. But here you can see the data of these three different randomized phase 3 trials that are extremely relevant in the field of metastatic colorectal cancer. In second and later lines, MSI high MSS status is also relevant. We have data with pembrolizumab, we have data with nivolumab plus ipilimumab or nivolumab alone. This is the Keynote 164 study with pembrolizumab in MSI high tumors. Um, Different cohorts depending on the previous treatments. It's not randomized. The pembrolizumab Q3 weeks to administer to these patients led to clearly responses. 33% of the patients had an objective um, uh, response, with especially a long duration of response. And similar results were seen with nivolumab. However, nivolumab plus ipilimumab, although again that's not randomized, it's not a randomization here of nivolumab versus nivolumab plus ipilimumab, but nivolumab plus ipilimumab in cross-trial comparisons, response rates were relatively high. And even if you project the curves of progression-free survival and overall survival, as you can appreciate, the PFS and the OS for pre-treated patients with nivolumab plus ipilimumab was a bit better compared to nivolumab alone, although, again, these were not randomized data. But it looks as if the combination of a PD plus a CTLA-4 antibody in this situation may lead to a bit more activity in this situation. There's all series of checkpoint inhibitors that is under development. We have seen data from different Chinese checkpoint inhibitors in upper GI cancer. We have seen the data with dostarlimab from the Garnet study, dostarlimab, which was recently approved by the FDA for patients with a deficient mismatch repair tumor, advanced solid tumor, not only colorectal cancer, so an MSI high solid tumor. And indeed, with this PD antibody dostarlimab in patients with an MSI colorectal cancer or non-colorectal cancer, there was a relatively good response rate, as is illustrated on this slide, which was around in a non-randomized study around 40%. And based on these data, the FDA has approved recently this anti-PD antibody also for patients with MSI-high tumors. Looking into another marker, um, BRV 600E, and Dr. Kopetz will expand more on that in just a moment. The Beacon study was a randomized study in second and third line chemo standard FOLFIRI plus cetuximab versus a doublet encorafenib cetuximab versus a triplet encorafenib cetuximab plus the MEK inhibitor binimetinib. The two experimental arms were better compared to chemo. The triplet was not better compared to the doublet. And if you look at the different subgroups, because we did further analysis to see whether there are any subgroups that may be we have more benefits from a triplet versus a doublet. What is that's not yet clear. We cannot yet determine which subgroups are there. But what is clear is that consistently in the different subgroups, looking at prior treatments, at prior number of lines, at prior types of treatments, the BRAF targeted treatment was always better compared to chemotherapy alone. We're also looking at some markers at MAP kinase expression, looking at the CMS, at at different biomarker types in this situation. And what was indeed seen is that patients with the CMS type 4 and the biomarker type 1 showed an increased response rate and a trend toward the deriving benefit, more benefit from a triplet regimen, but that's not yet validated. We need to look a bit more as well into some of the immune inflammatory gene sets that were associated with OS benefit from the triplet. But as far as today, the doublet and encorafenib cetuximab is a standard option for these patients. Looking further in some data, I mentioned to you already the data of chemo plus an angiogenesis inhibitor. These are again the data from ramucirumab plus FOLFIRI in this situation, just to repeat that in this situation. And looking at another group, another biomarker is HER2 overexpression. We know that 3 to 5% of patients with metastatic colorectal cancer are HER2 positive, either by immunohistochemistry, either by amplification. Some patients are HER2 mutation. These data here were in patients with HER2 positive on immunohistochemistry or amplified tumors. Different data with different combinations. Showed that in RAS wild type, most often left-sided tumors, that's where this HER2 positivity is clustered, led to activity. And indeed, if you look at the different trials as that you saw on the previous slide, but also that are summarized here, the different combinations, trastuzumab, lapatinib, trastuzumab, pertuzumab, or the antibody drug conjugate, trastuzumab deruxtecan, there was also consistently high activity in this situation. Today, we do not yet consider that as a treatment for first line. We look into especially left-sided RAS5 type tumors, whether they are too positive in later lines, second or later lines, and then may consider one of these treatment options, which are not yet approved today. Interesting recent data presented at ESMO in Paris in September are on the subgroup of patients with the KRAS mutation, KRAS G12C mutation in this group, and there we have seen that KRAS inhibitors are active in lung cancer in this G12C mutation. In colon cancer, sotorasib, which was active in lung cancer and approved in lung cancer with this mutation, was not active in colorectal cancer. At ESMO, we saw some interesting data looking at the combination of sotorasib plus panitumumab plus an EGFR antibody. I remind you to the data in BRAF 600 mutations blocking the pathway at different levels. With this combination in data from non-randomized studies, early studies, small cohorts, sotorasib plus panitumumab was active, led to some activity, led to some responses in some patients. But even more appealing were the data that were presented at ESMO in the presidential session on adagrasib, which is another KRAS G12C TKI. With this molecule alone, there was some activity in these patients, but especially, and that the response rate was around 22%. But especially if you look in a cohort, a small cohort of around 28 patients, where patients were treated with adagrasib plus cetuximab, so again blocking the pathway at two different levels. In these 28 patients, there was an objective response of 43%. So this was one of the important relevant data at ESMO. So it's not yet practice changing because it's small cohorts. Phase 3 studies are being launched right now with this combination, but it's important. And if I see today a patient with a RAS mutation, I want to not only to have a report and say that says it's the RAS mutation or a KRAS mutation. I want to know which mutation it is, because it seems that this G12C mutation, which is present in only 3 to 5% of the patients, is druggable. Of course, we need to have a bit more data in this with these combinations. And just looking at some other data sets, the question, what about checkpoint inhibitors in combination with TKIs in microsatellite stable tumors? Regorafenib plus nivolumab, the initial Japanese data were astonishing. Later on, we saw some disappointing data coming more from the US. While there were a few patients who responded with an MSS tumor to the combination of regorafenib nivolumab, but probably not enough, 7%, as you can see, not enough to take this forward as really a major breakthrough. However, at the recent meetings earlier this year, we saw interesting data with another combination for microsatellite stable tumors coming from the LEAP-05 study with the combination of pembrolizumab plus levantinib, a TKI, that in which we saw in 32 patients an objective response of 22% pre-treated patients. So again, a non-randomized small cohort, but maybe some music in this type of combinations, and there is a plan to study that further. And you can see the waterfall plots of this combination, pembrolizumab, levantinib. And finally, another interesting approach are the data in later lines with new data with TAS-102 plus or minus bevacizumab. This is a randomized study, but a randomized phase 2 study coming from Denmark, where patients with TAS-102 plus bevacizumab and a longer progression-free survival, a longer overall survival compared to patients treated alone with TAS-102 or trifluridine. So the PFS and the OS was lower, but we need phase 3 data, and the phase 3 study is finishing right now. We're waiting results of a randomized phase 3 study to see whether in later lines we'll go for combinations trifluridine, TAS-102 plus bevacizumab. And finally, just apply this knowledge to make it a bit more concrete. In the final slide, on a case, a patient, 63 years old, who presented with asymptomatic metastatic colorectal cancer. The tumor was the RAS, KRAS, NRAS, and BRAF wild type. Patient had good organ function, he had metastasis, non-resectable metastasis with large retroperitoneal lymph nodes. Patient was in good condition. If the tumor is MSI high in this situation, it's right-sided tumor. The standard option today, as I mentioned, we would go for pembrolizumab, although there are randomized data studies ongoing of PD antibody alone, in this case, Nivo plus or minus ipilimumab. So it may well be that in the future, combination may be more active. But today, I would advocate that it's PD antibody alone. If the tumor on top of the MSI high status has a BRAF V600E mutation, The question is, what should we do first? Usually we say that we would go first for pembrolizumab, not yet in first line with encorafenib, cetuximab, plus or minus bimitinib. Bimitinib, I've shown you the data of the ANCHOR study, which are appealing. But in this situation, we need a bit more data from phase 3 in the first line before implementing that. And on top of that, if the patient has as well MSI high and BRAF600 mutation, and we know that there's sometimes an overlap, because of the longer response duration, we usually go for a checkpoint inhibitor alone in the first line. If the patient progresses, if David tumor progresses on the previous therapy, if we've chosen for pembrolizumab, we may go in second line either for chemotherapy, FOLFOX, FOLFIRI plus an angiogenesis inhibitor, or plus an EGFR antibody, but probably more for an angiogenesis inhibitor. It's the right-sided tumor. Or an option could be also that we go from BRAF targeted therapy in this situation. I would determine my choice based on the tumor burden in this situation, and encorafenib cetuximab because the patient was not yet pre-treated with chemo, but both are really options for these patients. And in third line, depending on which sequence we are, if there are still cytotoxic options, if patients was not yet treated with FOLFIRI, then of course that would be FOLFIRI plus bevacizumab or an EGFR antibody. That's what I would do, plus or minus bevacizumab. Maybe in the future plus bevacizumab, but we don't have yet phase 3 results. Or regorafenib, then not with the dose of 160 milligrams, but with a clearly more tolerable strategy and dosing, with starting with lower at 80 or at 120 milligrams, and then if patients don't have toxicity going up, this it is shown that more patients will go on longer with regorafenib in this setting, and that this is better tolerated. So really, our treatment algorithms are becoming richer. We do have clearly more treatment options for our patients, and that's illustrated in this case. And Dr. Kopetz will now continue with some of the important aspects, really digging a little bit more in some of the biomarker data for patients with the metastatic colorectal cancer. Scott, the floor is yours.
Thank you very much, Eric, and thank you for your nice presentation that really set the stage. And I wanted to expand on a few areas today and talk a bit about some of the options for biomarker-driven therapy. There are really two different diseases when we think about colorectal cancer, and I think one could even argue that we could divide things up even further, but really recognizing that what we're dealing with are patients that have a chromosomal instability biology and those that have microsatellite instability. And and already heard some about the clinical implications of that, and we'll dive more into this. We know that there are many differences between these two types of cancer. We think about chromosomal instability as having a loss of heterozygosity, aneuploidy, that really we don't see in MSI high, which has a lot of more stable chromosome. There are certainly the majority of patients that are metastatic have chromosomal instability. We think about 85% of all colorectals, but more than 95% of metastatic patients have a chromosomal instability subtype. And likewise, MSI high then, and 5% or under in metastatic disease. There are some differences in terms of co-occurring mutations and tumor locations. We'll talk about some of the clinical implications of this as well. But one of the most important messages that I wanted to leave you with today is really the question about what sort of testing should be done for patients in 2021. What would we consider the minimum biomarker testing? And I'll share some of this data and the rationale behind this to leave you with this key point. Think about testing for RAS mutation. Now, of course, we know RAS is not a gene, but really is a nomenclature and shorthand for two different genes, KRAS and NRAS. And we think that mutations in either of these can behave very similarly, and we'll come back to this point. Additionally, BRAF testing should be done specifically for BRAF V600E. There are other mutations that can occur, but we'll be highlighting the relevance of the V600E. And then as also discussed, the testing for MSI high is critical. Now, let's go into that last one a bit more, because this is an area that sometimes there remain questions about this. So this is the text from the guidelines, a little dense here, but really acknowledging that that mismatch repair or deficient, microsatellite instability testing is really recommended to be done. And this should be done in appropriate laboratories. And there's a number of ways that would be accomplished. And we'll go through some of these. It could be by PCR for MSI, IHC for protein expression, or some of the NGS panels are now incorporating this into it. Now, there is an algorithm that abnormal MLH1 should be followed by some testing to really help understand if it's sporadic or germline. But this observation that if you have a concurrent MLH1 promoter methylation or a concurrent BRAF mutation, that means that this is a sporadic MSI and not a hereditary syndrome. But I think a key message here, not to get really lost in the details of the type, universal testing is recommended for all patients with colorectal cancer. Not just metastatic patients, not just patients who have a family history of colorectal cancer or some suspicion of a germline predisposition, but really should be done uniformly. And this is based on both our understanding of the clinical importance of this for therapeutic decision-making, but also the fact that the Amsterdam, Bethesda criteria in the past really were not sufficiently sensitive in finding patients with HNPCC, Lynch syndrome, and that really universal testing is recommended to identify affected families. Okay, so let's talk now about KRAS, and certainly KRAS is not a new biomarker, and we like to think of it as the biomarker that started it all over a decade ago. And the concept here and the clinical relevance of this mutation is really based around the recognition that it is a very meaningful predictive biomarker for EGFR inhibitors. And I think this is well recognized now, but what we see is that when you have an activating RAS mutation, that upstream signaling is no longer relevant, so that the use of an EGFR inhibitor is no longer beneficial to these cells, because they are driven by this activating RAS mutation, and we get this MAP kinase signaling that is prevalent. So let's just review some of the data, historic data behind this. KRAS is a biomarker for panitumumab response. So here's some of the data looking at the use of panitumumab, the EGFR inhibitor, in refractory patients. This is a study randomizing best supportive care with or without panitumumab. And you can see really striking curves on the left and the right where you see a separation and a benefit with panitumumab and the wild type KRAS that you don't see in patients with mutated KRAS. The same is seen and initially described actually in the cetuximab randomized study in the New England Journal of Medicine, where here you can see, again, similar best supportive care versus cetuximab, a very clear, now looking at overall survival distinction, overlapping curves in the presence of a KRAS mutation and a clear separation with wild type. Now, the field has gone on to really describe that KRAS and NRAS mutations, both in codons 12 and 13, but also other ones such as 59, 61, 117, 146, These are all activating mutations that then are associated with resistance to EGFR inhibitors. Now, we know there are other biomarkers, and over the past several years, we've recognized that further precision oncology incorporates the location of the tumor as well. And so we've known for several years that tumor location is prognostic. And this is a figure just showing as the increasing degrees of red on the screen, the worse outcomes. So it's notable that right-sided tumors have worse prognosis. And actually the worst is up at the hepatic flexure. But also know that this is predictive for EGFR inhibition. A crystal study under leadership of Dr. Van Cutsem and others really helped define the benefits of cetuximab for patients with, in combination with FOLFIRI. They're previously untreated. And this is a very nice analysis that was done that I think is one of the clearest to help define the impact of sidedness and the benefit of an EGFR inhibitor. So this is isolating the effect of cetuximab alone versus, combined with FOLFIRI versus FOLFIRI alone. And what one can see is both for progression-free survival and overall survival within a RAS wild-type patients, a strong improvement in PFS and OS for left-sided patients, appropriately on the left side of your screen, but really overlapping curves on patients on the right side, right-sided tumors. Now, there's always questions about what to do with a transverse colon, and perhaps we can talk about that a little bit later, and I think the data is a little mixed in that regard, but clearly between the right and the left-sided colon and where the rectal cancers are included in the left-sided disease is both prognostic as well as predictive. Now, when we look at the impact of VEGF inhibition, this is the 80405 data. I would also highlight the FIRE3 data there as well, although that's, I don't have time to show that today. But this is a randomized study of FOLFOX or FOLFIRI as a first line, randomized to cetuximab or bevacizumab. So it was a physician's preference on the cytotoxic backbone, randomized then to cetuximab or bevacizumab. Now, lots of curves here, and I'll try to take you through these. But if you look at the numbers, what one can see is that there is a benefit with the use of these monoclonal antibodies, but it differs based on the location. And what we can see first is that for the left-sided tumors, and now you may see this arrow here in the middle, these are patients that have better prognosis, but you can also see a median overall survival of 39 months for the cetuximab treated in the left side, and 33 months for bevacizumab in the left side, and this was statistically significant. Conversely, now when you look at the right-sided tumors, you can see that these are tumors that have better outcomes with the use of bevacizumab, also a statistically significant finding. So this is really critical information that helps us better tailor our initial treatments for patients. Now, I will say that that certainly this requires discussion with the patients and the toxicity and trying to balance the best options for a patient. Now, what about some up-and-coming biomarkers? HER2 amplification is one of these. This is present in about 4% of colorectal cancer patients. There is a trend towards mutual exclusivity with RAS and BRAF wild-type patients. Prevalence of about 7 or 8% of the RAS wild-type and BRAF wild-type tumors. And this HER2 amplification then is an oncogenic driver. So, and that's what this mutual exclusivity also tells us, that it's rare that you need both in a tumor, that this really is a key driver. And there's been a number of really promising data that have demonstrated benefits with combinations here. And here is some of the initial studies looking at the doublets of trastuzumab and lapatinib. You can see activity here, response rate of 30%, and duration very meaningful at almost 9 months. These are for patients that have an IHC of 3+, so really strong staining, or IHC of 2+, and by FISH, some evidence of amplification. Now, other combinations have also been demonstrated, trastuzumab, pertuzumab. Again, very similar response rates, as you can see here, and duration of response. This study was notable when they then went on to exclude the KRAS mutated data patients, the outcomes were even better. A third combination that we don't have time to review today, but I just highlight the emerging data on trastuzumab and tucatinib. So we look forward to more data here, but I think really acknowledging that targeting HER2 with a combination of antibodies or antibody and a TKIs to the pathway may be beneficial. Additional data that has recently been presented is using an antibody-drug conjugate to HER2. Now, this is different in that this is not treating or inhibiting the signaling of HER2, but using HER2 as a way to deliver a drug conjugate. In this case, a topoisomerase inhibitor, deruxtecan. So this DXD is a very potent payload. It works much better than some of the microtubule payloads in earlier generation ADCs. What you can see is a very nice waterfall plot here, great duration of progression-free survival in these patients. This is a 7-month PFS, and you can see the waterfall plot here. This agent is also showing activity in patients that have been treated with prior kinase or antibody therapy. So you can see the yellow triangles in the top left figure showing activity even in these patients. So we do think use after targeting HER2. There is toxicity associated with this, just to be aware of, some of the drug-induced pneumonitis. So some familiarity with the drug is warranted with a close attention to any pulmonary symptoms in patients. Now, other areas have been explored for colorectal cancer include NTRK fusions. These are rare, less than 1%, but absolutely can be evidence of activity and something to be considering in our patients. The question is, when and how to test for fusions, and this really depends on the availability of this testing within your practice. Now, let's talk again about MSI-high. We've heard about this, but I think it's such an important point to reiterate, and we'll talk a little bit more about the different types of testing here. So we know that MSI-high tumors can be acquired MSI, somatic, or germline, and we talked about different methodologies for testing, and just acknowledging here that the different terminologies, and sometimes the language we use to describe these can be confusing. So you'll hear terms like deficient mismatch repair that really is applying to testing where the IHC was done and you lose particular proteins, these mismatch repair proteins. Or MSI high, which is terminology that is related to PCR testing. In clinical practice, we can use these terms interchangeably, and so I don't want to get hung up on the details of when one term is preferred with the other, but really we can think about deficient mismatch repair, MSI high, as really synonymous. And the question is always, what to order and when. Again, the key is to do any test that you are most comfortable with. MSI again, will be the PCR test, very sensitive, uh, mismatch repaired, IHC, likewise very sensitive, easy to do. The only point I would make is that if there's a high clinical suspicion and you've done one test and it shows microsatellite stable, but there is a family history or other concerns, you may think about the orthogonal test. But at least in my practice, and we can be interested to hear from Dr. Van Cutsem in our discussion later, but at my practice, I'm doing one testing modality and only doing a second when there's that clinical suspicion. Okay, as mentioned before, MSI can be evaluated on next generation sequencing panels, and that's now in the guidelines. So there, won't get into the details, but just know that there's a number of different platforms that can assess these. And we think in general, these are very reasonable options. So if you're doing NGS sequencing and have a panel that can also assess MSI, that can be reasonable. The same caveats would apply if, however, there is evidence that we need that there's a clinical suspicion. Please do think about the orthogonal testing. So, why reflexive testing? And again, we want to belabor this point because it's so important. Certainly, there are prognostic implications and potential to guide adjuvant therapy for our stage 2 patients. But certainly in advanced disease setting, the use of a PD-1 inhibitor for MSI is really compelling and should be utilized. And then as mentioned, this can help pick up patients with Lynch syndrome for genetic counseling. So to reiterate this point, certainly wanted to share again some of the data on MSI high tumors responsive to PD-1 inhibition, just showing very nicely the activity in a more refractory setting with pembrolizumab or nivolumab with or without ipilimumab, as shown here. And I think as Dr. Van Cutsem mentioned, certainly wonderful data in the first-line setting that is beneficial as well. Now, we'd be remiss if talking about biomarkers if we didn't kind of acknowledge the fact that we now have opportunities to do circulating tumor DNA and liquid biopsy testing. And the ctDNA tests are now showing very reasonable concordance with the tissue testing, especially in untreated metastatic patients or patients progressing on disease, and certainly can be another modality for testing for patients. Increasingly, though, we're also seeing these being incorporated in detection for minimal residual disease, really enabled by the fact that these are being utilized for very high sensitivity assays. Being able to detect one mutant allele in a large background of wild type patients or wild type DNA in plasma. So just remarkable technology that now is allowed us to really understand and define a new category of kind of minimal residual disease, where we are recognize that this liquid biopsy is now more sensitive than even our best imaging tests, and we can detect patients that may still have disease despite surgery, and can be using this to help guide decisions around adjuvant therapy. And these are studies that are ongoing. So this is a technology that is moving rapidly to the into the clinic, and I think clinical trials are really ongoing to help define how we should best use these. But we'll get results that really look like this. This is one of many different platforms here that has a very high specificity. So if patients have the disease or mutation seen in the plasma that match what is seen in the patient's tumor, that really defines with a near 100% positive predictive value that there's disease that remains. And you can see the sensitivity and prevalence here, and really remarkable curves that separate out patients with really good prognosis with those that inevitably given time will recur. So this is an area of active research, as I mentioned, treatment escalation in early stage disease, especially where adjuvant therapy is not being considered. or de-escalation? Can we identify a population that have outcomes that are so good that further adjuvant therapy is no longer warranted? And then finally, thinking about novel treatments for patients who have minimal residual disease despite all of our standard of care therapies. So in conclusion, for this section, we have a number of mutations that affect treatment selection. Patients with RAS mutations, of course, not responding to anti-EGFR. Patients with BRAF V600E mutations respond poorly to anti-EGFR therapy. And some of Dr. Van Cutsem's presentation on the role of BRAF inhibitors in this setting, and then checkpoint inhibitors effective for MSI tumors as well. So best practices for interprofessional team-based care, I think, is an important thing to end up on. And just acknowledging that all of these are key to participate in molecular testing, that we need to keep the patient central in all of this and help navigate a patient through this testing. Certainly some of this testing has implications for the family and involving genetic counselors. Really how we describe the type of testing and the results really require a collaboration with a pathologist as well as our mid-level providers and nursing as well. So, patients really want to know, what are the benefits of testing? Why should I do it? How will these test results affect treatment? Always a high concern about implications for family members and whether the testing indicates the seriousness of the disease, both for the patient as well as other family members. And patients want to hear this from us. So I think it's important that we're conversant in what these biomarkers mean and also can explain them clearly to our patients. So, just a conclusion here as well, kind of that, again, hopefully reiterated at this point, mismatch repair testing is a standard of care for all colorectal cancer patients. Thinking about some of the current precision therapies for BRAF, HER2, NTRK, MSI, RAS mutations. I think I'd be remiss not to highlight that there's a very interesting emerging data around G12C inhibitors for KRAS, and that we may be able to have therapies as a positive predictive biomarker for KRAS in the future. And then certainly the field of circulating tumor DNA is helping to advance things further.
Thank you very much, Scott. This was a very interesting and excellent overview. And listening to the two talks, it's clear that we're moving towards personalized therapy in colorectal cancer. We're not yet there. But if you look in some of the progresses that were made the last 10, 12 years, there is quite a lot has been happening. Individualizing patients based on molecular characteristics, but also on clinical characteristics. You heard some aspects on sidedness, for instance, but also the presentation, the location of the metastases are extremely relevant in order to come up on the intensity of a treatment regimen also. And then the molecular unraveling is clearly progressing. And important also is that we have been able to discuss different immuno-oncology agents, different targeted agents that make a difference for some patients. There is still a long way to go. The immunophenotyping, the consensus molecular subtypes of colorectal cancer, and the further future, also looking into transcriptomics and single cell analysis will help us really to further unravel this and to make progress in the benefit of patients. So that was great. We have several questions that you've been asking, and let's look at the selection of some of the questions. It's obviously, Scott, that liquid biopsies and looking into circulating DNA may have different applications in metastatic disease, but also in more early disease. In stage treat colon cancer, for instance, there is a question, where do you see and how would you apply uh, looking for circulating DNA with liquid biopsies before starting chemotherapy, at the end, after the operation, or at the end of the chemotherapy, and would you use that also in the follow-up more or less frequently than looking at eventual relapse with scans?
Yeah, I think it's a great question, and it's an area that's rapidly changing. I think when we think about biomarker testing for stage 3, absolutely MSI. Uh, question about the utility of other mutation testing in that for prognosis, and then circulating tumor DNA, as the audience member asked. So it is something that we consider and perhaps utilize in very selected cases. We really need the clinical data to understand how to use that to guide therapy and when we should be de-escalating or escalating, for that matter. So where we do have the testing done, and we're not doing it routinely, it's really used to kind of guide the interval of surveillance, like how closely should we be paying attention to a patient. But I think really we need the clinical trials to really understand how to best utilize that. So, Eric, I see some other questions here about immunotherapy, which is always an area of continued evolution. So, one of the most common questions that I get, and just like this question from the audience, is, when would you use a monotherapy checkpoint inhibitor, and when a dual checkpoint inhibitor? And what are the side effect profiles of those, and how does that kind of impact that decision?
And that's indeed an important question, a difficult question, but in my practice, I use most often in the first line treatment of an MSI high metastatic colorectal cancer, uh, PD antibody alone. Pembrolizumab is approved in Europe in this indication. We have data with the combination of a PD plus a CTLA-4 antibody. We have data with nivolumab plus ipilimumab with low doses of ipilimumab, 1 milligram per kilogram, in combination with 3 milligrams per kilogram of nivolumab. This regimen is a bit more toxic, but although with this 3 and 1 milligram ipilimumab, it's feasible. Um, we have data from non-randomized phase 2 studies showing that the combination of Nivo plus Ipi is active, and in cross-trial comparisons, the response rates compare favorably with the PD antibody alone. The strategic key question is, should we start in first line with PD or PD plus ETL4? That's not solved yet. Until we have more definitive data in my practice, also because that's the label, we start with pembro monotherapy, and then we may consider later on, if the patient doesn't benefit, to go for combination IOs in this situation.
Well summarized. So another question is, sometimes we have patients that have more than one biomarker to target, and trying to understand, which one to go after. The question is, in patients that have a BRAF V600E mutated tumor, and maybe we'll start off with MSI high in newly diagnosed, what approach would you choose? Would it be a kind of a chemo-targeted therapy, or would it be an immunotherapy?
Yeah, if a patient has an MSI high tumor and in combination with the BRAF V600E mutation, we would usually start with PD antibody with a checkpoint inhibitor in the first line. And then if they fail, we may go on either for combination IO, either for probably more frequently for combination and coraflip cetuximab for the targeting the BRAF V600E mutation. Although there's not a big difference across trial comparisons in the response rate, the response duration for checkpoint inhibitors is usually much longer, and that's why most of us tend to favor to start with a checkpoint inhibitor first.
I think completely agree. So the corollary question from the audience then is also about, well, what if it's a microsatellite stable but has a high tumor mutation burden? How would that impact your choice?
Yeah, that's a more difficult question where I guess there is probably no consensus. High tumor mutation burden is not in the label in Europe for checkpoint inhibitors. In the US, it's different. Um, if the patient has a high tumor mutation burden due to a poly or 4D mutation, there are anecdotal reports that these patients clearly benefit from checkpoint inhibitors, and also the high TMB may benefit from a checkpoint inhibitor. But based on this data and based on labels, maybe I would start in these patients with in second line with encorafenib, cetuximab, and then later, if patients do not respond, we may consider if we can get access to a checkpoint inhibitor for the dual mutation burden high patients. I don't know what's your idea on this, Scott, whether you would do the same or whether you really go for the IT after the ITM.
Yeah, I think you summarized our practice very nicely as well. There's underwhelming data about borderline high tumor mutation burden, right? 10, 15, mutations per megabase range really is not responding to PD-1 inhibitors in colorectal cancer, unlike other tumor types. Now that the exception are the POL-E, POL-D mutations where we're looking at 50 to 100 mutations per megabase, these really ultra mutators, and they tend to do very well, but those are extraordinarily rare. And so I think we've been using less and less PD-1 inhibitors for those just over the threshold colorectal cancer patients.
Thank you. I really have to disappoint some of you that we cannot continue because I would love to continue this discussion. It's always so nice to discuss with you, Scott. Thanks so much for that. And also, thank you to the whole team of Peerview for setting up this program. Please do not forget to visit us at peerview.com, colorectal cancer 21. You can download the slides, watch and replay this event. You can join the conversation on Twitter at Peerview, and you can download also your CME certificates. Thank you very much to the whole team and enjoy all of you and thanks Peerview.